Bonjour.
All right, this is supposed to be a fireside chat, so I don't know where the fireplace is. We definitely have the Eiffel Tower, so let's call it the Eiffel Tower side chat. Tell us a little more about the model of Ilara Health. I think it's
Sure.
a very interesting one, very innovative,
Yeah.
somewhat complicated. So please
Yeah,
give us the explanation
absolutely. So
and make
we
it.
build we build a technology-enabled primary care model for the emerging middle class in Africa. So just to put a bit of context, we often say that there's no access to care in Africa. Well, there's actually a lot of access to care. Kenya has 20,000 small primary care practices and about 40,000 chemists. France has, I don't know, maybe 6,000 GPs, I don't know, and maybe 10,000 pharmacies, I don't know, but significantly less. So access to care is actually very wide, but the quality of care is the problem. All those small medical practices are not run by doctors, are run by nurses or by clinical officers, which is a sub-medical profession. And when you get there, you may be given an antibiotic, and then you go, and then obviously it's not going to solve your problem. You come back, you're given another antibiotic. So bottom line, the care is extremely fragmented, lack of quality, lack of understanding from those medical practitioners for what those patients need to be given and how they need to be treated. So we believe that through giving those clinicians whatever they need to become better clinicians, we can identify the best ones among those 20,000 and support the best ones to become better clinicians, therefore to bring better care, therefore to deliver better care to the patient. So how do you do that? We started with diagnostics because this is something I'm super passionate about. So we started to bring diagnostic devices, so kind of like think of the mini laboratory, so a bunch of portable diagnostic devices in those primary care facilities to be able to detect the basic metabolic markers, so your cholesterol, your blood pressure, blood sugar, your full blood count, your even kidney, liver panels, to be able to identify things before they really become bad. And then we continue. So we started with diagnostics, but then we continue with other things that those clinicians need. They make most of their money by selling meds. So we actually finance those meds, but we finance the better meds than the very cheap, low-quality meds. We finance those small practices more than just diagnostics and meds. We place some of them, they want beds because they need to do some inpatient. Some of them, they want some other assets. But how do you do that? We place a technology platform on top of them, so we can understand their financial flows, their patient flows, their patient medical data, so we can identify the best clinicians and deliver whatever they need to become even better.
Who do you partner with on doing this? And I'd be tempted to say even more as you grow. Like, how is partnership? How is collaborating with other organizations an important piece of what you do?
Absolutely. So look, I mean, our primary partners are actually the clinician, like, let's call them clinician entrepreneurs, right? So I strongly believe I don't believe into building new clinics in a market which has too many, but I believe in partnering with the best. We need to identify the best first. But the second, because we build this layer above those many small primary care facilities, and we become a platform for whoever wants to and needs to plug services and products into those clinicians. So be it pharma companies, be it portable diagnostic device companies, being insurance companies, there is very little insurance penetration because there's no payment data or patient data. So we partner with all the players that need to plug into the primary care ecosystem in this mid to low income care population in Africa.
Are there partners that are more difficult to convince than others? Is the reception good on what you're presenting?
I think there's a lot of kind of misconception that primary care is not a profitable space, and there are a lot of companies who try not to touch that space. But unfortunately or fortunately, this is the space which delivers care to 97% of the people. Like, we talk about 2.7% insured people in Kenya, right? So I mean, in France, we're all insured, right? We all have the social security. Just 2.7% private insured and about 25% the national insurance, which doesn't really cover outpatient. But we've tried to demonstrate, I strongly believe in delivering value for everyone, and we've tried to demonstrate there is a way to build a profitable, economically viable model in primary care in Africa, and then it works.
Tell us about what you see as the biggest barriers or challenges that
Yeah.
you've had as you built the
Yeah.
business and as you're going to continue to grow.
Yeah. So I think the first one is really fragmentation. And I often say, you know, when I came to Kenya the first time, it was like 2015, I was living in a place where like 5 people selling or 20 people selling bananas in the street. And I was asking a friend of mine who runs one of the successful retail tech companies in Kenya, why there are 20 people selling bananas instead of being a supermarket? And he said, because no one has money to buy a fridge. So kind of like bring the comparison into care. No one has enough money to buy whatever they need to build a proper medical facility. So that's why there are like so many. So fragmentation is not the primary challenge. Access to that many small clinics in the big outskirts of the city is not easy, so operational difficulty. But even more than that is really the medical. I think Anil, you're talking about medical understanding of the deep science behind the care, because we're not talking about doctors, right? We talk to nurses who maybe have studied some kind of medicine, 10, 20, 30 years ago. So it's really the lack of prescription of diagnostic, the lack of prescription of proper medicine. And that's very difficult actually because we're not financed to go and then train really. We're not financed to bring those clinicians back to med school. So that's one of probably those are the two big challenges. And the third one is that really we talk about out-of-pocket care, right? People pay from their pocket their $100, whatever they make a month, $100 to $200 per month per family. They need to pay for care, and obviously consultation is a loss leader, is zero. And they pay for meds and they pay for other things, but they pay out of pocket every time they need to go there. And actually, they go to see one of those clinicians only when things go really, really wrong, and then they pay whatever it takes to get better. So lack of a payer is probably one of the biggest issues.
How do you solve that? Is that the role of your company? Is that the role of others?
So for now, we solved. When I look at healthcare, there are usually 3 actors, right? There is the provider, the care, there is the patient, and there is the payer, right? In most of those countries, the payer and the patient is the same, right? So for now, we've solved the provider side, so trying to help providers to become better providers and deliver better care, and we're going to move now into the patient care. So can we build an insurance model based on that network of primary care facilities that we kind of control to be able to deliver some kind of subscription model, like outpatient insurance, into that network to the patients accessing that network. And the thing is that most of the people in those markets access this primary care, massive, wide distributed care system.
I have a question to you to get back to what Clément was saying earlier on, and the fact that there are millions of solutions out there, millions of ideas, loads of dynamics behind it, loads of people who want to do good. What made your solution doable? Like, what's the secret sauce for making something doable, making it work, and then scaling?
So I still remember one of our early stage investors told me, Emilian, you can afford not to make significant revenue in the early stage of Ilara Health. But one thing you cannot afford is not to understand, as well as those primary care providers, or even better than them, how do they think? And I was still spend most of my time in the field with those primary care providers. Sometimes I even go and camp. I mean, funny enough, I have a car with tents, and I go and then camp in the village or in the outskirts, trying to spend as much time as I can with them to understand how do they think. So I think this is also what helped us to understand that those providers think day by day. They don't think, okay, I'm going to have a system which is going to improve my processes, etc. What can I sell or give to the patient for an exchange of cash, of money, for me as a clinician to make money and be able to pay my staff and to deliver better care to the patient? And this is something which so we've started to bring into those clinics products and services which bring an immediate cash incentive to that provider. And we started with those diagnostic devices. I do a blood test, I'm going to pay $3-4, and I'm going to get my full blood count done. I'm going to pay 50 cents, and I'm going to get my blood sugar, etc. And that's the basis. And then we started to come with anything else which, again, brings a cash incentive, a financial incentive for the provider, for the providers to make revenue, and for the patient obviously to benefit from this. So, and then only afterwards we brought a system, which obviously the system is very difficult to make money from SaaS models, from electronic medical records models in that market, where providers do not pay for systems. So we use the systems as a backbone and as a data collector platform to be able to identify the best providers and support the best providers with that product or that service, which makes them money for them to be able to survive and deliver better care eventually to the patients.
Thank you for that. How do you see your progression going so far? You're in sub-Saharan Africa. Are you planning on going to other regions of the world? Are there regions where it's more difficult, less relevant? What do you think?
Look, I strongly believe that the decentralized care and the decentralized diagnostics model is something which is applicable to everywhere, right? And I mean, even if you look here, I'm not sure here in France, but if I step into a Boots in London or in a CVS in the US, I can do some blood tests, right? So kind of the idea of that centralized laboratory which cost $1 million to build is a bit obsolete, right? I mean, you can still do a lot of complex blood tests in a lab, but you can do a lot of tests at your provider and eventually home. I still see a future where we're going to have something, a machine home, and then put a finger inside in maybe 10 years from now and get a bunch of blood markers, and this is going to go directly to our providers, and the provider will call us and say, hey, come to see me because I see there is a problem, right? So this model works everywhere. Now, what we do in Africa, and specifically in Kenya, is a very, very simple part of this model. It's a simplified version of a decentralized care model based on data. Now, the way I look at the progress, we are now in about 1,000 of these 20,000 primary care small clinics in Kenya. 10,000 of them, so half of them are private. We're in about 1,000 of them, but 1,000 represent pretty much 30% of the total small providers where it is worth to do something, because the rest are too far, too small. So we've been very, very wide, and now actually get much deeper in the best ones. So there's a lot of work to do in depth in Kenya, but there are a lot of markets around first. So I wouldn't even think of outside Africa. There's a lot of markets around where we can replicate the same thing based on technology and identify the best clinicians and give them this clinic in the box, this perfect provider in a box with the devices, with the technology, with the knowledge to make them become better clinicians. And then we can go in other places in the world.
Easy.
It's actually not easy. It's actually, if it was easy, I think many other people would do it. It's not easy, but it's extremely impactful. It makes me so happy that I can see with my own eyes how patients going there now, they can avoid being amputated because of diabetes, right? Or waking one morning and not seeing well because of a kidney failure. So this is what makes me thrive and makes me happy, because we can make immediate impact with very, very simple things.
In a few words before we finish, if you had a magic wand, what would you do?
A magic?
Magic wand, in Baguette Magic. What would you like to solve in terms of healthcare? It's
really, I'm a big believer in prevention, and if I was, and I know it's very, very difficult in places where really people do not think of the future, thinking, what do I eat? Do I make enough money today to bring a piece of bread to my kids, right? So they don't think of eating healthier or living healthier or going for a run, etc., right? They have different problems. But if I'm able to solve a bit, at least the basics, and detect the things that can be detected today and avoid that people get into type 2 diabetes, or even reverse, right? I mean, type 2 diabetes, if I'm not wrong, I'm not a doctor, but is reversible through lifestyle. So there are a lot of things we can do there. And, if I manage to impact, 100,000 people's lives today and then maybe 1 million people's lives in a few years, it would make me extremely, extremely happy. And I don't think that's a simple thing. That's a result of multiple actions into this ecosystem, and we're really building this ecosystem with different bricks by bricks. There's no magic solution, in my opinion.
Thank you very much. This brings us to the conclusion, and thank you everyone today. I think today we've seen that innovation, technology, AI, you can stay here, it's okay. We're just, you know, are important. We also need dedication, persistence, vision, personal drive also that we've heard to really enable better access to healthcare globally. We've also seen that tech, innovation, drive are not the panacea. Access to health is a very challenging issue. That's why we still have half of the world population without there. So there are multiple layers to it and many things to still invent. Funding remains also an enabler. But overall, I think, and it builds very much on what you were saying, is that it's access to healthcare challenges actually need system-wide changes, and it's only the complementary capabilities of many different actors that can really help to move the needle on this. So I'll conclude on that. I thank you very much for attending. I hope this session was inspiring. I was very inspired by our speakers, so thank you very much to all of you. A warm thank you to Anil, to Nikolai, to Alexandre, Clément, and to you. And very much looking forward to continuing the discussion with all of you.
Thank you,
everyone.